Hi, good evening, everyone. Today, I'll talk about the latest ISUOG guidelines for the third trimester scanning. ISUOG has published recently the latest guidelines uh, regarding the third trimester scanning. So, the International Society of Ultrasound in Obstetrics and Gynecology is a scientific organization that encourages sound clinical practice and high quality teaching and research related to diagnostic imaging in women's health care. So, systematic assessment of the impact of routine third trimester ultrasound examination has provided robust estimates of its diagnostic accuracy for fetal anomalies, small for gestational age, large for gestational age, as well as some adverse perinatal outcomes. The document outlines recommended guidelines for this are conducting third trimester ultrasound examination, encompassing determination of placental location and fetal presentation, measurement of fetal biometry, identification of fetal anomalies, evaluation of amniotic fluid volume, and documentation of fetal and uterine artery Doppler findings. Sorry, just give me a second. The routine third trimester ultrasound scan should be performed. Finally, it discusses certain situations with additional steps and detailed assessment should be included in the third trimester ultrasound scan. Furthermore, this guideline does not address the content, frequency, or the gestational age of third trimester ultrasound scans in multiple pregnancy. Similarly, it does not address other pathologies or complications that would classify the pregnancy as high risk, such as preeclampsia, diabetes, and fetal growth restriction, some of which are covered in other ISUOG guidelines. So, what are the indications for the third trimester scan? The third trimester ultrasound scan can assess fetal viability, fetal presentation, anatomy and growth, amniotic fluid volume, placental location, fetoplacental Doppler. There are multiple other indications that can trigger a third trimester scan, including antepartum bleeding, reduced fetal movements, preterm rupture of the membranes, and suspected abnormalities of fetal growth based on the physical examination. Gestational age for third trimester ultrasound scan. The optimal gestational age for performing the third trimester scan is a trade-off between the optimal visibility of the fetal anatomy and the optimal accuracy of fetal growth assessment, and therefore depends on the objectives of the examination. Therefore, the timing of the ultrasound scan between 32 and 36 weeks should be decided based on the individual maternal and fetal characteristics, the risk level of pregnancy, and local objectives and resources. So, how is the technique? The technique for ultrasound assessment of fetal well-being and biometry, as well as amniotic fluid volume in the third trimester, are similar to those used in the second trimester and should follow the ISUOG fetal biometry guideline. Gestational age should be, if it is not determined in the first and second trimester, if the patient is coming to you first time in the third trimester, the gestational age should be determined using head circumference plus femoral length, or head circumference alone if FL is not available. Still, it has a variation of 15 days around the mean at 32 weeks. Assessment of fetal well-being in the third trimester include umbilical artery Doppler in high-risk pregnancies, and when indicated should include additional Doppler parameters such as middle cerebral artery, ductus venosus, and the uterine artery Doppler velocimetries. Regarding fetal anomalies, why fetal anomalies? We have done in second trimester targeted imaging. Some fetal abnormalities will not be detected during the second trimester anomaly scan, even with the best equipment in the most expert of hands. Broadly, there are two possible reasons for this. First, the anomaly was there but was not seen. For example, due to technical difficulties such as increased maternal body mass, index, maternal body mass index or fetal position. Secondly, the natural history of some fetal abnormalities that develop only or become visible only after the second trimester scan. These are typically anomalies affecting the genitourinary tract, central nervous system, and the heart. Some fetal abnormalities will not be detected at the routine second trimester anomaly scan. So I think I've done this slide, right? Right. Uh, So the potential benefits of diagnosing in the third trimester a fetal abnormality not detected at the second trimester anomaly scan include the opportunity to arrange for the birth for the birth to take place in a center that can provide the appropriate level of neonatal care, allow the parents time and counseling to prepare for the birth of a child with an anomaly. Perfect or to perform prenatal genetic analysis such as third trimester amniocentesis for chromosomal microarray or expand on tests already performed like expanding on chromosomal microarray with prenatal exome sequencing. Plan neonatal follow-up which may be missed when the anomaly is not visual when the anomaly was not seen on routine neonatal clinical examination and were indicated and permitted legally, like termination of pregnancy for anomalies with serious implications for the child. A third trimester structural examination could include the following. Structural examination, what do we do in head? A three standard deviation from the mean, and when pathological, is usually associated with cortical anomalies and a sloping head like scapocephaly and dolichocephaly, a marked deformation, especially when combined with a small HC or other deformations like plagocephaly, brachycephaly, trigonocephaly, and cloverleaf skull. And the anomalies in the brain include intracranial anechoic or hyperechogenic areas are abnormal, as is a smooth cortex like agyria, lissencephaly, or a cortex which is with too many small polymicrogyria or pachygyria or multiple sulci. Anatomy of the brain cannot be seen by the transabdominal route. In some cases, such cases, transvaginal approach is required. Heart. Normal cardiothoracic circumferential ratio in the third trimester is approximately 0.45 and should be no longer than 0.5. The the diaphragm should be examined in both in sagittal and coronal views. Approximately 20% of the congenital diaphragmatic hernias are detected only in third trimester. Fluid collections, calcifications, and cystic structures should warrant further investigation. Then bowel dilatation is also a common phenomenon during the third trimester, and most pathologies are associated with small bowel dilatation more than 14 millimeters. Urinary system. The upper normal limit for a renal pelvic AP diameter in a third trimester is 7 mm, and if it is more than 15 mm, is associated with increased risk for a need of postnatal surgeries. This guideline is also mentioned about the placental location in the third trimester. So placenta previa, the location of placenta should be examined in any scan performed in the third trimester. The placental position and its relationship with the internal cervical os should be identified, and the distance of the leading edge of the placenta from the internal cervical os should be documented. Placenta previa represents a risk of filamentous cord insertion, vasa previa, and these anomalies should be ruled out when assessing women with suspected placenta previa in the third trimester. Women with major placenta previa or uterine scar may be offered a scan at around 28 weeks, while women with minor placenta previa may be assessed later in the third trimester. In general, if the leading edge of placenta is 20 mm or more than the internal vaginal birth is considered a safe option. Placenta accreta system. Third trimester assessment of placenta is recommended if there is evidence that the lower placental edge reaches or overlaps the internal cervical os at the time of routine anomaly scan. Conversely, systemic screening for placenta previa, so for vasa previa or velamentous cord insertion, is not recommended in third trimester in view of technical difficulties and lack of robust evidence regarding its usefulness. A prior cesarean section, birth, C-section or uterine surgery, including myomectomy or multiple curettages in the setting of placenta previa, is associated with increased risk of placenta accreta spectrum disorders. Prenatal diagnosis of placenta accreta spectrum is associated with reduced hemorrhagic morbidity, and every woman presenting with clinical risk factors of placenta accreta spectrum should be referred for specialist assessment. Amniotic fluid, we have to have an eye on the amniotic fluid from the NT scan onwards. Sometimes what happens is the amniotic fluid is very less even while doing NT at around 13 weeks also. But we usually measure the amniotic fluid from the second trimester onwards. We usually take all the four quadrants. We make sure we're measuring the inner to inner one without any cord. We also put color, making sure that there is no vessels. We take all the four quadrants and then we measure that, and we see whether it is falling into the normal criteria, oligo or poly, so that uh, even having a general look at the scan while scanning also, we should be able to make out whether the liquor is good or less or more. This should happen even while doing NT also, just to rule out major abnormalities of the fetus, that absent kidneys or sometimes like Barters. So there's no fluid at all in the gestational sac.